is about tubular reabsorption. We have seen that there are three processes in the formation of urine. One is filtration, which we covered as glomerular filtration and its factor. Second one is tubular reabsorption, and the third one is tubular secretion. So in that tubular reabsorption, we are covering in 2 lectures. So let me share the slides with you. Okay, it will be in the window. Now, hopefully you are able to see my slides.
Yes, sir.
So this is lecture number 5, and it is regarding the reabsorption process only. So as I told you, that formation of urine means 3 things. One is filtration. That we covered it in glomerular filtration. Okay, we covered it in the lecture of glomerular filtration. Second process is reabsorption. Reabsorption. What is mean by reabsorption? Reabsorption is when the fluid is filtered or plasma is filtered in the through the Bowman's capsule and reaches to the tubule. Let me draw it here. This is a Bowman's capsule, and here we have got proximal convoluted tubule followed by loop of Henle, then thin segment and thick segment, and again it will convert it into distal convoluted tubule and collecting duct or collecting tubule. So those things which are essential for the body, like glucose, water, sodium, they will be taken back because they are filtered here through the glomerulus. They are filtered here. They are freely filtered, and if they are not taken back into the circulation, they will pass into the urine. They will pass into the urine. So we don't want them to be lost in the urine. So that's why there is a mechanism which we call it as reabsorption of the essential elements like sodium, glucose, water. Water and sodium we have seen in the previous class. Now we will see how the glucose is absorbed. How the glucose is reabsorbed. Plus, what about calcium? What about phosphate? What about potassium? All these are essential for the body. So in this class, we will be seeing reabsorption of glucose and reabsorption of potassium, reabsorption of phosphate, reabsorption of urea, and reabsorption of calcium. So these are the things we will be covering in today's lecture. How the glucose is reabsorbed, and simultaneously, while describing the reabsorption, we will discuss two things, two important parameters, which is or the terminologies, which is known as tubular maximum. Tubular maximum for any substance. Maybe it is glucose, maybe it is for potassium, but there is a term called as tubular maximum or Tmax. Then second term, which we will be describing or discussing, is the renal threshold. Renal threshold for glucose. Let's say, sorry, here it is renal threshold for glucose or for potassium, but we will describe what is the meaning of renal threshold, what is the meaning of a tubular maximum, and we are discussing mainly in relation to the glucose. Rest other things are easy to remember, but glucose, as it is an important thing, and it will be very common that if the person's blood glucose level is high, then there are chances that it will appear into the urine. So we will discuss how the urine will pass, or how the person will pass the glucose in the urine, what is its relation with Tmax and what is its relation with renal threshold. Okay. So let us begin with the objectives. So learning objectives for today's lecture is to discuss the Tmax, that is tubular maximum for any particular substance. And what is the meaning of renal plasma threshold? How much should be the plasma level of that substance, after which the substance will appear in the urine. Then how the renal is, how the kidneys are handling proteins, peptides, glucose. We will see glucose reabsorption, peptide reabsorption, then urea, chloride, potassium, phosphate, and calcium and magnesium. So these are the substances which will be reabsorbed because they are required for the body. Now, if you remember, I told you in the beginning or in the first lecture that the urine should not contain a protein. A normal person's urine is without any protein, without any protein. This was my statement. But this statement is contradicted in this lecture because it says that small or medium size proteins like angiotensin, this is an hormone, but it is also a protein in nature or peptide in nature. It can be found, or it is filtered, and it will be coming out into the urine. So there may be possibility that there will be protein present, but not in large quantity. Very negligible quantity, very, very minute quantity of protein will be found in the urine. For that, let's see the example like albumin. Albumin is the major protein. How much is the normal value for albumin in the plasma? Normal albumin level, heme block. 7.5 is the total plasma protein. Out of that, around 5 grams per 100 ml is the normal albumin. Out of that, or here it is written in in liters, not in ml. It is written in liters. That's why it is 50 grams per liter. One and the same thing. 5 grams per 100 ml or 50 grams per 100. Out of that, only 0.2% will be coming out in the urine, or it will be filtered, or it is present in the urine. So it is very, very minute quantity of urine is present. Of protein is present in the urine. But if it appears to be in large quantity, then we call this condition as proteinuria. Proteinuria is a condition where the urine will contain a substantial amount of protein, which can be easily detected by analyzing it. Okay. So basically, proteinuria, although in the normal person also it will be there, but it will be very negligible quantity. And once it is reabsorbed, let us say this is a renal tubule. Let's assume that this is a renal tubule. Starting, I will draw the Bowman's capsule here. So let us say this is the renal tubule, or you can say PCT. Let's say PCT. In that you will have the epithelial cells. PCT has got epithelial cell, and this is the lumen. So in the lumen, protein is coming. Proteins are some proteins, very little amount of protein is coming. It will be taken into the epithelial cell. It will be taken from the luminal border into the epithelial cells, and it will be degraded, or you can say metabolized or chopped into smaller pieces. Suppose this is a protein, it will be chopped into smaller pieces of amino acids. It will become amino acids. And then they will join to the blood. So although it is filtered, it will be present, but it will be taken back into the epithelium and in the form of small peptides or amino acids. So it's not a uh, uh, in a normal person, you can say protein is not present, or zero protein, or negligible amount of the proteins are there. How much is filtered? If suppose, let me change the color of the pen. Let us say, assume this is a glomerulus, this is PCT, and here is the loop of Henle. How much, or I will draw the arterioles also, then it will be very clear. These are the capillary ball, afferent and efferent arteriole. So at a normal GFR, What is the normal GFR?
125 milliliter per minute.
125 ml per minute. So 125 ml per minute is the normal GFR, or this fluid is filtered. And if you multiply with the how much plasma, how much a particular substance is present in a plasma. So plasma concentration, suppose plasma concentration of a particular substance. If you multiply this, you will get the amount which is present here. You will get the amount which is present in the tubule. In the tubule, this is known as tubular load of that particular substance. Filtered load or tubular load. Tubular load. This much amount is present. Multiply GFR with its plasma concentration. Plasma concentration. I will not ask you to calculate during the exam, or it is not mandatory, but just to explain you how we know that how much is the substance is coming into the filtrate, we have to multiply the GFR with the plasma concentration of that particular substance. This will help you in understanding the next slide. So total filtered protein is equal to GFR into concentration of protein in the filtrate. Concentration of the protein in the filtrates, which is around about 1.8 grams per day. 1.8 grams per day will be lost. Not 1.8 grams per day, but almost all the filtered protein is taken up. It is filtered, but after that it is taken up and then it will be reabsorbed, or you can say it will be converted into amino acid or peptide, and only 100 milligram per day are lost into the urine, which is not coming in our test or not detected. Okay. Coming to the glucose, how the glucose is reabsorbed in the renal tubule or in the nephron. Glucose and amino acids are reabsorbed by secondary active transport. So what is the mechanism? Mechanism of reabsorption of glucose is secondary active transport. What does it mean? Secondary active transport mean what?
Active transport, so it needs ATP, and
Yes.
secondary because it enters with the sodium.
Okay, good. So it is a transport mechanism, or it is reabsorbed because of utilization of the energy. ATPs are utilized, but secondary because it is not utilized at the same place. Maybe it is utilized at some other place, and because of that, there is a movement of glucose or amino acid is occurring. So if you imagine, let's say this is the renal tubule, or let's say proximal convoluted tubule, and this is the apical border of the membrane of the tubule, and these are the epithelial cells. So epithelial cells has got two borders. One is facing the lumen, right? This is luminal border. One is facing outside or maybe in the interstitium. We call this border total. This border is known as basolateral membrane. Basolateral membrane. So let's say proteins are here, or glucose is here as it is filtered. So on the luminal border, there are some channels, some carrier proteins are there. Some carrier proteins are there which are responsible for pushing these glucose into the cell. But these carriers will not function unless there is one different channel on the other side, or on the basolateral side. What is this channel or protein? It is sodium potassium ATPase channel. The usual sodium potassium ATPase channel. If this sodium potassium ATPase channel is there, its function is to do what? Its function is to throw 3 sodium out and take 2 potassium in. Okay. By this way, there will be always decrease in sodium concentration inside the cell. Okay. In the filtered fluid, there is sodium present in abundant quantity. So these sodiums can easily move into the cell because higher concentration is found in the tubular lumen and low concentration in the epithelial cells. And there are specific carrier proteins are also present. So this sodium will join glucose and it will move into the cell by a channel known as sodium glucose channel. This is simple. This channel will not function unless both of the parties will join here. If any one will attach, it will not function. So as you know, sodium is trying to move in. At the same time, glucose will also be moving in. Okay. So sodium glucose channel is making them to move in, but this channel is functioning because of the sodium potassium pump at the basolateral membrane. That's why it is called as a secondary active transport. And as let's say this is sodium glucose channel, this is sending the sodium inside and also glucose inside. Okay, both of them are going in same direction or opposite direction? Same direction. That's why it is called as co-transport. It is a type of secondary active transport, but it is known as co-transport because they are moving in same direction. If suppose one of them will move in the opposite direction, at that time it will be known as counter transport. Counter transport. Okay, so here there is no counter transport. Here is a co-transport. Also, another name for this co-transport is symport. Another name for this transport mechanism is symport. So sodium is moving inside the cell along with glucose through a channel known as sodium glucose channel or transporter. Sodium glucose, GL for glucose and transporter. So this type of carrier proteins are known as SGLT. SGLT. And these SGLT will be present at many places in our body. The one which is present here in the kidney, they are given a number which is known as 2 number, SGLT2. So SGLT2 will be responsible for reabsorption of sodium and glucose from the lumen into the epithelial cells. Once it comes here, let me draw another. Shall I remove this? Let me remove this. And I will draw only the cell now, epithelial cell. So same, here is the luminal border and here is the the basolateral border. And here are the channel. This is known as SGLT2, which will throw sodium and glucose together inside. Okay, glucose and sodium. What will happen to glucose now? Glucose will try to go because here are the capillaries. Here are the peritubular capillaries. Peritubular capillaries. Our aim is to stop the glucose from excreted into the urine. So we want them to back into the blood. So glucose will now move to the interstitium. And from the interstitium, it will move into the peritubular capillary. Again, it requires a special carrier protein here. And this carrier protein on the basolateral membrane is known as GLUT, G-L-U-T, glucose transporter. GLU for glucose and T for transport. And again, there are numbers 1, 2, 3, 4. Here, number 2 is present, GLUT2, because GLUT are these channels can be present in muscle, it can be present in liver, it can be present in GIT, anywhere. But here, which type is present? It is the type known as the GLUT2 transporter. So first step is from the lumen into the epithelial cells through SGLT2. This is a secondary active transport or co-transport. From here, glucose will go into the interstitium through the process of simple diffusion. higher concentration here, lower concentration here through the channel. So it will be GLUT2 transporters. And from here, when it will become excessive here, glucose is becoming excessive in the interstitium through bulk flow, it will be joining the blood. So it will enter into the peritubular capillary. So by this way, we are stopping the loss of glucose into the urine. Okay. Now, how much quantity is absorbed in the PCT? In the proximal convoluted tubule, 100% of the glucose is reabsorbed. Okay, 100%. It should not go to the second part. Now coming to the terminology which is known as tubular maximum. Tubular maximum means it is the maximum capacity of the kidney to reabsorb any substance, a specific substance. So what is the capacity of the kidney to reabsorb glucose is 375 milligram per minute. Which value we are talking about now? 375 in blood or 375 in the filtrate? Question mark. This is a question. This 375 is present where? 375 milligram of glucose is present in blood or in the renal tubule or proximal tubule. Where?
Tubules.
Yes, it is in the proximal tubule, or it is filtered, PCT. If you remember from the slide number 1, I told you what is mean by tubular load. Tubular load. How much quantity of fluid is present or how much quantity of a specific substance is present in the after filtration. So after filtration, if this is a proximal convoluted tubule, if the glucose quantity is up to 375 milligram per minute, if it is filtered here coming, if it is in this rate 375 milligram per minute, then it will be completely reabsorbed. It will be completely reabsorbed. If this quantity becomes more than that, let's say it becomes 400 milligram per minute. If it becomes more than that, 375 will be reabsorbed and 25 will be coming into the urine. In the urine, glucose will be lost. So this is the maximum capacity of the kidney to reabsorb any particular substance. Here it is glucose, that is known as tubular maximum. But why is this number? Why the kidney has got one specific capacity? What could be the reason? Why kidney cannot reabsorb more than this? Okay. Can anyone tell me what is the answer?
Load of
Why?
the load which transporters can do, or
No, why it is only 375? Why not it can absorb 400? If it is absorbing 375, then why not 400?
the carriers are full.
Because of the carriers?
Good, excellent. Because any substance which require carrier transport, it depends upon the number of carriers. If there are three, let's say one carrier can transport 1 milligram only. So if there are only 375 carriers in the tubule, then all the carriers will transport 1. Okay. After that, if it becomes 400, there will be no 25 carriers are not there. So it is the saturation of the carrier. It is the saturation of the carriers. When all the carriers are occupied, all of them are occupied with glucose, then there will be no more carrier available for the next glucose molecule, and it will start to appear into the urine. So when the filtered load of the glucose is around 375 milligram per minute, then all of it will be reabsorbed. Okay. If the filtered load increases more than 375, it will become or it will be coming into the urine. It will be coming in urine. Did you get my point? What is the meaning of tubular maximum for glucose? Is it clear?
Yes, yes.
Yes, doctor.
Yes, just like in a factory, if 10 workers are there and they can handle, suppose, 375 bags of sugar, they are pulling the 375 bag of sugar, 10 workers. If these 10 workers, all of them are working, all 375 bags will be loaded into the truck, or you can say into the body. If the number of bags increases, let's say becoming 400, then these 375 will be loaded and 25 will be remaining on the ground. They cannot be loaded because there are not enough hands or carriers which will be putting the bags of sugar into the truck or into the body. So that's why it will appear into the urine. This is the saturation. They will be doing their maximum job, and that's why they will not able to handle the excess amount. This is called as tubular maximum, and this is tubular maximum for glucose. It can be tubular maximum for phosphate. It can be tubular maximum for protein also. So a specific carrier, if it is there for handling any substance, then they will have limited capacity, a specific capacity. Now, what I told you in the beginning, that let's say how to calculate the tubular load, how much it is filtered, how much blood is filtered. So at the we have the formula. I showed you in the beginning the formula. Formula is GFR multiplied by plasma concentration of that substance. OK. So GFR is 125 if the person is normal kidney. And if suppose the glucose concentration is 100 milligram, suppose 100 milligram per 100 ml. So this will be the answer will be this 100 is cancelled. It is 125 milligram. OK. So 125 milligram of sugar will be present in a when the GFR is 125. GFR is normal or 125. If blood sugar becomes suppose 200, let's say assume it becomes 200 milligram per 100 ml. Then it will be 2 multiplied by 125, because this 100 will be this 20 will be cancelled. It remains only 2 into 125. How much it will be? 250 milligram. And we know 375 is the maximum handling capacity of the kidney. So still the sugar will be or glucose will be reabsorbed. If suppose it becomes 300, blood sugar level becomes 300, then it will be 3 into 125, which is 375 milligram. At that point also, all of the sugars will be will be absorbed. This means that the plasma glucose level should increase more than 3 times. Then only the urine will have glucose in it. Okay. The urine drop will have glucose in it if the blood or plasma sugar level goes above 300. But this is not the case. This is not the case. We will come to the second. Yeah, this is the one which I just told you, the calculations. If 100 milligram is the sugar level and 125 is a GFR, then tubular maximum can be, if tubular maximum is 375, it will all will be absorbed. Okay. Now comes the role of renal threshold. The term threshold means, don't be confused with renal threshold and the tubular maximum. Renal threshold is nothing but the plasma concentration of glucose. It is the blood glucose level. It is the blood glucose level at which it will start to appear in the urine. It will start to appear in the urine. Suppose my blood glucose level becomes 180 milligram. If you just check my blood glucose level 180 milligram, then I am sure that if you test my urine, suppose this is a urine, if you put a dipstick, it will be positive for glucose. Why? Because at this level, it will start to appear in the urine. This is called as a renal threshold for glucose. Renal threshold for glucose. So it is the plasma concentration of glucose, after which the urine will show glucose in it. Now you may be wondering why it is two values. 100 milli, either I can say 180 milligram or I can say 200 milligram. Why it is a range? The range is because it is different blood glucose level, slightly different blood glucose level in arterial blood and blood in the veins. So venous and arterial blood has got little different, not much, little different values. That's why we have to take the range. So if the blood glucose level is in between the range of 180 to 200, then the urine will become positive for glucose. That means tubular maximum will be reached at this time. Tubular maximum will be reached at this time. So this is called as renal threshold. But this is not so simple. The reabsorption of glucose and the renal threshold and tubular maximum are not so simple. There is one term called as splay, which I will try to explain you. For that explanation, we have to think about, we have to see the graph first. So this graph shows if we plot glucose filtered load, how much glucose is coming in the tubule. This is the nephron and this is the proximal convoluted tubule. So how much glucose is filtered or the glucose load if we plot it on the y-axis and the plasma glucose level, that is glucose present in the blood. If we plot it on the x-axis, so as I told you, what is the renal threshold after which it will appear into the urine? Not renal threshold. What is the tubular maximum? What is tubular maximum? Yes, 375. Let us put a mark at 375 here. So that means if the blood, if the anything is filtered freely, then it will start to appear in the urine. If the concentration in the plasma is increasing, it will be filtered more. So there will be a linear relationship. There is a straight, or you can say a line will appear. As you increase the blood glucose level, it will be filtered more. So this line will come. But we know that plasma at the level of 375 here, it will not be filtered. It will be start appearing in the urine. So this curve, all this curve will not be reabsorbed. All if it will be not reabsorbed, there will be starting of appearing into the urine. Similarly, excretion, that is, it will come in the urine. So till plasma glucose level of 200, there will be no glucose in the urine. If plasma glucose level becomes more, then it starts to appear in the urine. So it can be like this. The graph can be like this. OK. But if you observe the graph, it is not actually starting at this point. It is starting slowly, not as an angle, not like this, or not reabsorption is like this, making an angle. There is a smooth curve like this, and there is a smooth curve of excretion like this. Why it is happening? Why there is not exactly once 375 it is appearing, or why not at 200 it starts to appear? Because not all the nephron has got the same tubular maximum. Let us say 3 different nephrons are here in the kidney. Kidney has got millions of nephrons. Tubular maximum for this nephron may be 375 normal. Tubular maximum for this nephron may be 400. Tubular maximum for this nephron may be 200. So we take the average of all these different nephrons. What are their tubular maximum? It will appear to be 375. Now, suppose the fluid is filtered through this area, through this nephron. So in this nephron, fluid is filtered, which contain glucose. So if the glucose level load increases more than 200, it will start to appear where? It will start to appear in the urine. But for this nephron, still the same amount, if it is filtered, it will be all reabsorbed. It will all will be reabsorbed. For this nephron also, all will be reabsorbed. But one nephron is giving positive sugar. So that's why there is a curve is smooth, not coming on one exact point. It is known as splay. This is known as splay. To explain this, I gave example in the in one of the group that, you know, in the car, what is the function of brakes? What is the function of brake in the car? If you are driving a car,
Slow down the speed.
slow down the speed, okay, or stop the car, okay. The brakes are applied to stop the car. But is it like when I press the paddle or press the brake, immediately the car will stop here? It is not always like this. It is, there is some distance the car will travel. When we apply brake here, the car will stop at this point. This distance is known as splay. That means the actual brake is applied here and expected stoppage of car is happening here. Or you can say actual stoppage is happening here. Expected is the car should stop here. This gap is known as splay. So here also in the curve, when we say the renal threshold, if it is 200, then suddenly the urine should become positive. It is not becoming positive. It is taking slightly longer time. Even for reabsorption also, we say when 375 is there, the kidney should absorb everything, but it is not happening. It is still throwing out some of the glucose. This is known as the splay. The difference between expected level and the actual level is called as splay. Okay, so renal threshold in diabetes mellitus, what is happening in diabetes mellitus? Blood glucose level will be very high. So threshold level will be reached, and then the fluid which is filtered, or the plasma which is filtered, will have excess glucose. All the carriers will become saturated, and this excess glucose will pass into the urine, and the person will be labeled as having glycosuria. Glycosuria. Glucose in the urine. Okay. What are the 3 P's of diabetes? Clinical feature of diabetes are described as PPP. What are these 3 P's? Diabetes, endocrine finished now. Your endocrine block is finished. You should tell me what are the 3 cardinal features of diabetes mellitus.
Polyuria,
Polyuria,
polydipsia, and polyphagia.
Polyuria, polydipsia. So 3 polydipsia and polyphagia. Phagia. Okay. Why polyuria? Why excessive urine is there in diabetes mellitus? What is the reason? What is the reason of polyuria in diabetes mellitus? No answer. You finished the endocrine block and you are not able to tell me why it is happening. Why polyuria, excessive urine in it is not the kidney disease. It is the disease of endocrine system. It is disease of glucose handling. But why the glucose is positive in, or why, let's say positive. Okay, no problem. But why excessive? instead of you will see a patient will complain that he is waking up in the night and going to the bathroom frequently. Why?
Because of polydipsia and electrolyte imbalance.
No, polydipsia will come afterward. Once he will go for urine, then he will drink more water, and then he will have again it will go on. But why polyuria is occurring?
I think due to osmotic pressure or osmotic diuresis.
What is osmotic diuresis?
When the electrolytes become more,
Okay.
I'm not sure, but I think it's
Okay, you are right. When fluid is filtered from the glomerulus into the Bowman's capsule and reaches to the proximal convoluted tubule, if the person is suffering from diabetes mellitus, it will have more blood glucose levels, so more glucose molecules will come into the proximal convoluted tubule. Okay. If we have a solution where more solutes are there, what we call it as hypertonic solution, right?
hypertonic here.
Hypertonic solution. And if the solution which is without or little solutes, we say hypotonic. If these two solutions are separated by a membrane, then water will move from where to where? Water, I am telling water. From higher concentration of water to lower concentration, right? So suppose this is hypo area and this is hyper area. Okay. So water concentration is more in hypo or hyper? Here it is hypertonic solution, more glucose. Here it is hypotonic solution, less glucose.
We're in
So
hypotonic.
water will move from
Hypo to hyper.
Hypo to hyper. That means water will be moving to the here from here to here. But it is actually not moving. Instead of it, the water which is supposed to go here will not go. Okay. So instead of going or reabsorbed into the interstitium, it will remain here. So excess water will remain here. When excess water will remain here, little is absorbed, then it will go and come into the urine in the form of polyuria. This is occurring because of the osmotic effect, the effect due to solutes, excessive solutes in the tubule. That's why it is called as osmotic diuresis. In diabetes mellitus, the person will pass excessive urine because of the presence of glucose in the tubule, leading to osmotic pressure is raised, and this will lead to increased loss of water in the urine. This is called as osmotic diuresis. With this osmotic diuresis, there is one drug or one IV fluid which is known as mannitol. This mannitol is given in IV to a person who is having head injury. When we are expecting that there is a cerebral edema or edema in the near around the brain, then mannitol is given. This mannitol, what is this mannitol do? Mannitol cannot be absorbed by the renal tubules. It cannot be. There is no reabsorption of mannitol. Whatever filtered, it will appear here in the tubule. Because of this osmotic effect, the water which is supposed to be reabsorbed, it will be lost into the urine, and then the person's edema will be relieved. Edema will be relieved. This is the osmotic diuresis and its its usage. Okay. Okay. Now, up till now, we've covered the absorption of glucose. Who will summarize how the glucose is absorbed? What is Tmax? What is renal threshold? And which type of absorption is occurring? Okay. Who will summarize? Few, just 2 sentence, 3 sentence only. In Arabic also, no problem. Quickly, so that we can finish our lecture quickly. Anyone can start. What did you understand by, or up till now, what you understand about renal handling of glucose? How the kidney tubules are handling the glucose? Yes, Turkey. No one?
Yes, doctor.
Yes. Tell me about how the kidney handles the glucose. Tell me something, how it is carried, how it is reabsorbed, which segment it is reabsorbed, and what is Tmax, what is renal threshold.
Only one of them.
Anything you like. Where it is reabsorbed glucose?
Proximal convoluted tubule.
How much percent?
100%.
100%. Good. Excellent. What is the type of transport, reabsorption transport, how it occurs?
Secondary active transport.
Very good. Secondary active transport. Along with?
Sodium.
Along with sodium. Which channels are utilized? On the luminal border, on the basolateral border.
On the
Which?
luminal border,
Hmm.
SGL2.
Okay, SGLT2. And what is on the basolateral?
Sodium potassium interface.
And for glucose, we are
And
talking
I
about.
forget that.
And GLUT2, SGLT2 and GLUT2. You may be thinking why I am going in detail about the numbers and these things, right? But this is not useful. This is useful for remembering some drugs in pharmacology, which can block these SGLT2 so that the sugar level will be maintained. Okay. Or there are drugs which are responsible for acting on the GLUT. So pharmacology will also be coming after this lecture, or maybe once you read, the pharmacology people will say SGLT2 blocker or GLUT2 stimulator or something like that. So that's why. Okay, what is Tmax for glucose? How much is the Tmax?
375.
375. This is plasma glucose level or tubular fluid level? Glucose level in the tubular fluid. Is Tmax
Glucose level in the tubular fluid.
in the tubular fluid. And what is renal threshold for glucose?
Plasma concentration of glucose.
Plasma concentration. What is the value?
From 180 to 200.
180 to 200 milligram per deciliter or per 100 ml. So this is about the glucose transportation by or glucose handling by the kidney. This is a summary. Coming to the second ion, which is reabsorbed by the kidney, are chloride. Chloride are negatively charged ion, so they are reabsorbed through their electrochemical gradient because of their electrochemical gradient. So this is a renal tubule. Along with it, these are the cells. So it is negatively charged ion and passively reabsorbed. Once the sodium goes in, because of the positivity increases here and chloride are negative here, so they will be going into the cell. Okay. Usually they pass through the in between the cells. They will pass in between the cell to neutralize because sodium will come here. So chloride will also come here to neutralize the positivity here. So it is not directly controlled by the kidney. Chloride reabsorption is not directly controlled by the kidney. It is in relation with the sodium or in relation with the any positive ion. This is about chloride. Okay, another interesting chemical which is present in our body and continuously produced is urea. From where urea comes into our body? What is the source of urea in our body? Urea is a byproduct of which metabolism?
Protein metabolism.
So it is coming from protein metabolism, and in our diet and in our whole body, protein metabolism is continuously going on. So continuously urea is produced in large or small quantity. When we eat more protein, more urea will be present. If we have less protein, less urea will be present. So how the kidney, and this is a waste product. It is a waste product. It is not utilized. But again, this waste is also helpful for our body. This waste is also helpful for our body before it is eliminated, before it is excreted. So it is freely filtered. It is freely filtered. From where? From this glomerulus into the Bowman's capsule. So urea is freely filtered. There is no, if more urea is there, more urea will be filtered. Once it comes here in PCT, what is happening? If you remember sodium and water, sodium is reabsorbed. Water is also reabsorbed. Again, water is coming in or easily reabsorbed. So what is happening? The urea concentration go on increasing. Why? Because the fluid is lost or water is reabsorbed. Urea is not reabsorbed here. So it will become concentrated till it goes down, till it goes down. Initially, it is like this, less concentrated. Once it goes down, it is becoming hyperosmolar, hyperosmolar solution. Because of this hyperosmolarity inside and less hypoosmolarity outside, urea will be reabsorbed into the interstitium. So let us say 100% is filtered. Once it reaches to the tip of the loop of Henle down into the medulla, it will be 50% will be reabsorbed. Okay, out of 100, half will be, let's say, like this. Suppose this is I will draw it with a different color. Sorry. Let's say this is a urea molecule, 100%. Okay. By the time it comes here in the tip of the uh, or down into the medulla, because of hyperosmolarity, 50% will be reabsorbed. This half circle will be reabsorbed. So half circle is remaining here. Okay. Then what is happening when the fluid passes up, goes up? From here it goes up. This will be now urea is more in the interstitium. What will happen? It will join again. This half is coming from here, this half. And rest other half will join it here. So it will become full. So 50 first is reabsorb, then it will be no, first is first it is reabsorbed, then it will again join here. Once it reaches to the tip down in the before the collecting duct or in the collecting duct, when it goes down before the urine is lost or it will be excreted, again this 50% will leave and come back into the interstitium. This 50%, once it comes here, half will be inside and half will be into the interstitium. 50% will be in the interstitium. So this half will be lost into the urine. So we can say urea is 50% excreted. Excretion of urea is 50%, not 100%. Although it is a waste product, but it will be excreted only half. Now you may be thinking why so many things are happening, why it is first reabsorbed, then secreted, then reabsorbed. What is the purpose? Can anyone guess what is the purpose? Sorry. What is the purpose of so many things happening with the urea? Because urea is helping here. This urea is helping in making the medulla or medullary hyperosmolarity. Hyperosmolarity. It is creating medullary hyperosmolarity. Because of these solutes, this area will become hyperosmolar, which is used for regulation of the water output or water reabsorption, regulation of, you can say, concentration of the concentrating and diluting mechanism of the urine, concentrating the urine in conditions when we are not drinking or fasting at that time, or maybe in the hot weather, the urine color becomes dark because it is concentrated. And this concentrating mechanism of the urine is helped by urea because of this process. In this process, this urea is controlled by with the help of ADH. ADH will decide this urea to be excreted or not excreted or reabsorbed. So last part is under the control of antidiuretic hormone. Antidiuretic hormone. So it is freely filtered, reabsorbed, and secreted. All three processes are happening for urea. Absorption, filtration, absorption, and secretion. So out of 125 ml per minute, 44 ml per minute will be reabsorbed, and rest will be 50% will be 50% of the filtered urea will be lost into the urine. And the last part of the urea, that is 50% excretion in the urine, is under the influence of ADH, under the influence of antidiuretic hormone. Once antidiuretic hormone is released, it will causes increase urea permeability, and it will be leading to loss of urea into the, or the hyperosmolarity is created. Got it? Are you following with me or sleeping now?
Yes, doctor, following.
You are following. OK. So this diagram is showing you how the filtrate, which is coming into the proximal convoluted tubule, by the time it reaches down at the end of the proximal convoluted tubule, it becomes concentrated. And because of this concentrated, it will be passively reabsorbed into the interstitium and again join the peritubular capillary. And then again in the last part will be again secreted. So filtration, reabsorption, secretion, all the three processes are happening with urea, and ultimately 50% will be lost into the urine. OK. Another third important ion which is present in the filtrate is, after sodium, is potassium. What is the use of potassium in our body? What is the function of potassium in our body?
Important to the heart.
Important to the heart. Why? I will say no, it is important to the brain or the nervous tissue. You will agree with me or no?
Yes.
So potassium is useful, or it is the one which decides the excitability, of the excitable tissue, any excitable tissue. Which excitable cells? Maybe a muscle or maybe a neuron. Muscle could be a skeletal or smooth or cardiac. Skeletal, smooth or cardiac. These are the muscles which excitable tissues, neuron or muscle. The electric or membrane potential is mainly decided by or helped by the potassium. Membrane potential is decided by the potassium. So if potassium and if you know, suppose this is a cell, this is ICF and this is ECF. What is ICF, ECF? What is meaning of ICF and ECF?
Intracellular fluid, extracellular fluid.
Yes, intracellular and extracellular fluid. And potassium is maximum where? Potassium is present both inside also, it's outside also. But where it is maximum? No idea. This is very advanced level and you are not able to say where potassium is high. 98% of the potassium is inside the cell. And only 2% of the potassium is outside the cell. Okay. Whenever we are eating or drinking any drink, it contains maybe potassium. So this potassium will be added here in the 2%. In this 2%, potassium is present both inside and outside, and 98% is inside and 2% is outside. So whenever we are eating and drinking, it will be added to the plasma, which is extracellular fluid. And there is a very important role of potassium in excitable cells. So we have to regulate this 2%. And the kidney is helping in regulation of the potassium ion critically. Kidney is regulating the potassium ion concentration because we are eating anything and we are not bothering about how much potassium is there or not. Otherwise, what will happen? The excitable tissues will become inexcitable, or either they will go in paralysis or maybe becoming hyperexcitable because of both. It causes hyperexcitability also. It causes also the paralysis, you can say, or non-excitability, change in the potassium concentration. So both will be happening. And kidneys are regulating the potassium concentration. How? We will see it in this next slide. Potassium is filtered, reabsorbed, and secreted. All three processes. It is filtered through the in the glomerulus, from the glomerulus and into the Bowman's capsule. It is reabsorbed in the PCT and different parts of the tubule also. And again, it is secreted. Okay. So let me show you the. Okay, before I show you, let us discuss the other thing. So excretion can vary from. Sometimes potassium will be only 1% present in the urine. Sometimes it may be present around 110%, around 110%. So wide range. Sometimes it is excreted in a very little quantity. Sometimes it is in the large quantity, depending upon how much potassium is present and what is the level of aldosterone. Aldosterone is the hormone responsible for regulating the level of potassium or excretion of potassium. Also, it depends upon what is the acid-base status of the body. Acid-base status of the body. Either body is in what you call acidic state or basic state. In that condition also, potassium excretion will be changed. It is tightly controlled by the kidney. It is freely filtered in the glomerulus from the glomerular capillaries, then actively reabsorbed by the proximal convoluted tubule around 65%, because all values in the PCT are 65 to 67%. Okay. So same amount will be reabsorbed in the PCT. When it reaches to the ascending limb of loop of Henle, suppose this is a loop of Henle. When it reaches to the ascending limb, there is a channel which is known as sodium potassium 2 chloride channel. This will also help in reabsorption of the potassium. Once it reaches to the DCT and the collecting tubule, and based on the acid base status and how much aldosterone is secreted, the potassium will be either less secreted or it will be lost into the urine. We will see it now. This diagram is about, let's say, 356 milli equivalent per liter of the equivalent per day is filtered. Suppose these are potassium ion. Out of that, 65% is reabsorbed here in the PCT, 27% is reabsorbed here, 4% is reabsorbed here, and 12% is lost in the urine. 12% is lost in the urine. This 12% depends upon presence of aldosterone. How much aldosterone is secreted and what is the acid base status of the body. Acid base status of the body. Right? So based on these values, the amount of potassium will be more or less in the urine. So in the distal convoluted tubule, there is a specific cell, special cell, which is called as principal cell. This is now I am drawing the diagram of DCT, or you can say collecting tubule. Here there is a special cell which is known as principal cell. Principal cell. So this principal cell is receiving or under the control of, let's say this is the blood vessel. So it is bringing aldosterone here. Aldosterone is a which hormone? Fat soluble hormone. It will enter into the cell and it will cause action over the nucleus or the DNA, which will lead to the formation of new channels which are known as potassium channels. Potassium channels are formed because of the action of aldosterone. So whenever potassium is are to be lost, this will easily pass into the from the cell into the urine, or you can say tubular fluid, which will be ultimately going into the urine. This is how the action of aldosterone is deciding the amount of potassium to be excreted in the urine by inserting more and more potassium channels, And you know, potassium is coming from here through the basolateral membrane by sodium potassium ATPase pump. Sodium is going out, 3 sodium, and 2 potassium is coming in. And from here, it will be going into the tubular fluid. It is called as secretion, which is under control of aldosterone. Same thing is shown here. Aldosterone combined with the cytoplasmic receptor, hormone receptor complex will initiate the transcription of the nucleus in the nucleus, and then new protein channels will be formed. These new protein channels will be lying here on the luminal border. Sorry, not this. And this will allow the potassium to be secreted and going into the urine. It is going into the urine, potassium. This is how regulation of the potassium is happening. This is occurring in P cell or principal cell. This is special cell in the late distal convoluted tubule or collecting tubule. Same thing is shown here. Potassium from the blood will come into the interstitium, then through a sodium potassium ATPase pump reaches to the principal cell, and principal cell with the action of aldosterone will cause more and more channels on the luminal border, which will allow the potassium to be excreted out. How phosphate is reabsorbed? Okay. Phosphate and calcium, they are together. Phosphate, depending upon their plasma concentration, 85% of the filtered phosphate will be actively reabsorbed in the PCT, again by along with sodium sodium phosphate co-transporter. So when sodium moves in, phosphate will move also in. Phosphate will also, sorry, PO4 minus 3. So this is how, again, through the secondary transport. But there is one difference, like not like the glucose, where glucose Tmax is 375 and renal threshold is about around 180 to 200. Here the renal threshold is same as that of their normal blood glucose level, normal phosphate level. So if phosphate level increases in, there will be more phosphate will be lost into the urine. More phosphate will be lost into the urine. The phosphate reabsorption is under control of parathyroid hormone. Calcium and phosphate regulated by parathyroid hormone. So parathyroid hormone causes reabsorption of calcium and inhibiting the phosphate reabsorption. Sorry, I told you in a different way. But phosphate parathyroid hormone will cause calcium reabsorption and loss of phosphate. This is the action of PTH or parathyroid hormone. It is reabsorption and it is secretion, or you can say excretion. Increased phosphate in the urine is known as phosphaturia. Similarly, calcium and magnesium will also be reabsorbed in the PCT and thick ascending limb of loop of Henle. 90% of the filtered calcium will be reabsorbed there. 8% of the filtered calcium is reabsorbed in the DCT and CT. Again, it is under control of parathyroid hormone. So parathyroid hormone will increase the reabsorption of calcium. If its absence will lead to loss of calcium in the urine. Magnesium is also reabsorbed in the PCT, thick ascending limb of loop of Henle, and DCT. So other waste products like uric acid, creatinine, phenol are not passively reabsorbed as urea. So urea is the smallest particle of the waste products. Therefore, it is only product which is passively reabsorbed, whereas other products like uric acid, creatinine, and phenol, they will be lost into the urine. This is the summary. You can read it when you are free. It shows what is happening in the proximal convoluted tubule, about which are reabsorbed, which one is secreted. Similarly, in the distal tubule and collecting tubule, which ions or chemicals are reabsorbed and which are secreted. So it is a summary of the 2 lectures. Last point for today's lecture is, what is the minimum quantity of urine? Minimum urine quantity a person should pass to get rid of the waste products. To get rid of the waste product, how much should be the minimum quantity of urine a person should pass? This is known as obligatory urine volume. Obligatory means must. This is the must amount of urine should be passed. So they calculated in a 70 kg normal human being with everything is normal, healthy person. The person has to excrete almost 600 milliosmoles each day. Each day they have to secrete or excrete 600 milliosmol per day. If the maximal urine concentrating ability is 1200, the amount of concentration a kidney can do is about 1200 milliosmol. This is for human. Animals can have different hyperosmolating capacity. So if we consider this is the maximum, this is by research, it is found that is 1200 milliosmol. So how much is the urine a person should pass to get rid of this 600 milliosmol? Is about half a liter. Half a liter of urine must be passed to get rid of all these waste products. If suppose he is passing only 300 ml, 300 ml in 24 hours. So what will happen? The waste products will increase in your body. In the body, their concentration will go on increasing and they will have side effects or abnormal effect on the body. So that's why it is said that the normal or minimum in amount of urine a person must pass is about 0.5 liter or 500 ml per day. Why? Because minimum 600 milliosmol has to be excreted by the person. This is all about the lecture of reabsorption. So we have seen reabsorption of sodium and water in the previous lecture. In this lecture, we have seen reabsorption of glucose, reabsorption and secretion of potassium. Secretion will again come in the next lecture of potassium. And also we have seen how the urea is reabsorbed. Plus, we have seen little bit about how the chlorine ions are reabsorbed. What is the minimum quantity of urine one person should pass to get rid of the to get rid of these solutes, abnormal solutes or waste products. This is called as obligatory urine volume. Okay, so this is all about reabsorption. If you are online, is there any difficulty? If you are listening to me,